Good day. My name is Imelda Williams. This presentation is part C of the abnormal radiographic appearances of the pelvic girdle and lower limb, and it includes the ankle as well as the foot. So before you start part C, please ensure that you have gone through part A as well as part B. The referral rules for ankle x-rays, these are called Ottawa ankle rules, and x-ray should only be clinically indicated if the patient is unable to weight bear or if there's tenderness at the tip of the distal or 6 centimeters from the posterior aspect of either malleoli. In terms of the ABCs for the ankle, you should have a mortise view as well as a lateral as a minimum. The x-rays should be such that you can visualize the soft tissue, and on the AP view, the distal tib and fib should form around the mortise, and on the lateral view, the malleoli should overlap, and very importantly is that the base of the fifth metatarsal should be included. In terms of alignment, there should be uniform joint space in the tibio-talar as well as the talofibular joints, and the fibula should overlap the talar dome on the lateral view. Similar to all of any of the x-rays where you are looking at bone is to check for any avulsion fractures near the joint, and also any breaks in the cortex, and here it will be within the tibia, the fibula and the talus. And as mentioned already, the joint space should be uniform. And then with the soft tissues, inspect the soft tissues around the malleoli, and then see if there's any displacement, in particular of Kager's fat pad. Now I have included again some of the radiographic views and labels, and it will be useful to use the link that I've put in from Bontrager to ensure that you can identify the radiographic anatomy on the views of the ankle. So that is the lateral view. And then common fractures of the ankle include horizontal fractures at the ankle joint, so distal to it, and this is mostly due to an inversion injury, and eversion injuries can result in spiral fractures at the distal tibiofibular joint or distal to that. And then also inspect the ankle for fractures between the inferior tibiofibular joint as well as the head of the fibula, and here we're thinking of a Maisonneuve type of injury where you have the ring-like structure between the ankle and the knee. So for avulsion fractures with an inversion injury, this can result in a pull of the calcaneofibular ligament. Eversion injuries tend to have more severe fractures, and here we can see that there's a trimalleolar fracture where you've got the fractures of the fibula malleola as well as the tibia, and then also of the posterior malleoli with disruption of the ankle joint. Now, the Dennis-Weber classification, and that's probably something that you know quite well. So if the fracture is below the ankle joint, then it's a type Dennis-Weber type A. If it's at the level of the joint where the tibiofibular ligaments are still intact, that is a type B. And if it's above the joint, this normally tears the syndesmotic ligaments, and that will be a type C. Now, here I've got 3 images, and this is the type A, which is below the ankle joint. Type B is at the level of the ankle joint and the joint is still intact, and then type C is above the ankle joint. Another classification that can be used, of course, is the Potts fracture classification, which also has 3 types. Type 1 is where there's a spiral fracture of the lateral malleolus. Type 2 is where there's a spiral fracture, as well as avulsion of the medial collateral ligament, and could also include avulsion of the medial malleoli. And then type 3 is all of the above, but also includes a fracture of the posterior malleolus with anterior dislocation of the tibia. So here we have a bimalleolar fracture, and here we can see there's a fracture of the distal fibula as well as on the medial side of the medial side of the tibia. And trimalleolar fractures, on the AP it's easier to see fractures of the malleoli. However, for the posterior malleolar, quite often that's much better appreciated on a lateral view. And you can see this is quite a severe injury, and this is called a butterfly type injury, where you have got fractures of the fibula, and these are comminuted fractures. And in a case like this, it's really important that the knee is included, and especially so that the head of the fibula and the neck can be appreciated to see whether there can be associated fractures as well. Now, when stress views are taken, the reason for that is to look whether there's some tilt within the talar, and the angle is formed by lines drawn along the tibial plafond and also the dome of the talus. And it's quite useful to do comparison views of the contralateral ankle. A tilt of 15 to 25 degrees suggests that there is ligament injury, and if it's greater than 25 degrees, that is always abnormal. And this you will find in the textbook by Greenspan and Beltram, and that's also available as an ebook online. Now, talar neck fractures are the second most common type of fracture of the tarsal bones, and they may involve the head, the neck, the body, or the posterior process. Now, there's a Hawkins classification for talar neck fractures, and this is based on damage to the blood supply of the talus. And Hawkins use as a guide the healing prognosis, whether there's a risk of osteonecrosis, and also indication for open reduction. So a type 1 fracture, according to the Hawkins classification, is where the talus is undisplaced. Type 2 is where there's displacement, and then type 3 where there's displacement but also rotation, and this then locks in the talus behind the sustentaculum tali. And again, that comes from Greenspan and Beltram. So fractures of the talus, and in particular of the neck, has the added complication of non-union or avascular necrosis. And then you can also have osteochondral fractures. These are very subtle fractures, so it's always useful to look around the talar dome to see if there's any small flakes of bone which can indicate that there is an osteochondral fracture. Now, a Tilot fracture is a vertical fracture, and its extension from the distal articular surface. So in the pediatric patient, we could have a juvenile Tilot fracture, which is a fracture through the epiphyseal plate. So it's a Salter-Harris type 3 fracture. CT scans is really useful to request, as it will show you the extent of the injury. Tilot fractures tend to occur commonly within the age group of 11 to 15 years. Patients normally has a mechanism of injury of extreme eversion as well as lateral rotation of the ankle. Calcaneal injuries occur commonly as associated with the fall from height, and then also not to forget about the association with T12L1 compression fractures due to the force when the patient lands on their feet, and then the force goes through the central body, and naturally there's flexion at T12L1, which can then cause compression fractures. The lateral view is quite useful for the calcaneus, as most of the fracture should be visible on the lateral view of the calcaneus. So things to look for is disruption within the cortex, see for if there's any sclerotic lines, which means increasing density, which would indicate that there is compression, and then also to check bolus angle. Now just a word of caution with bolus angle. Greenspan, for example, indicates that bolus angle should be between 20 to 40 degrees. However, if you read rabies textbooks, they have it as 30 to 40 degrees. So depending on which author's book you read, there could be variation with bolus angle, but it should never be less than 20 degrees. Our bolus angle is measured by drawing a line from the posterior superior margin of the calcaneus to the tip of the posterior facet of the subtalar joint, and then also from the tip of the posterior facet through to the superior margin of the anterior process, and it's that angle that's measured. Angle of design is also called the critical angle, and it's formed by the downward and upward slope of the calcaneal dorsal surface, and that angle should be between 125 to 140 degrees to be normal. If it's greater than 140 degrees, that suggests that there is a fracture of the posterior facet of the subtalar joint. Now the soft tissues around the ankle, it will just show you damage to the soft tissue. It can give you an indication of the severity of the injury, but for example, if the Kager's fat pad is affected, it does not mean that there is a definite fracture. So Kager's fat pad sits just anterior to the Achilles tendon, so it's quite a useful to look at Kager's fat pad, which is this triangular density. The fat pad can be displaced or it can be totally obliterated depending on the amount of either effusion or if there's any bleeding around the ankle. So on the lateral view, if you want to look at the Achilles tendon on plain X-ray, then a low KV is very useful. And on this image, for example, you can see that there is a lumpy soft tissue mass, which is close to the arrow, and there's also some faint calcification within the injured Achilles tendon. However, it's our other modalities such as MRI and ultrasound which is much more useful to identify Achilles tendon tear. Now, it can be quite confusing when it comes to normal variance and whether you are looking at a fracture. So fractures can be simulated by accessory ossicles and also vice versa, where you can think it's an accessory ossicle and then it's actually a true fracture. The main thing is to look at the piece of bone. Avulsion fractures, normally the margins are quite sharp. They are not well corticated, and if you look very carefully, that piece of bone should fit somewhere close to where it came off. So see if there's, even if it's just a small speck of on the bone closest to that, where there's a decrease in density and where that can fit into that piece of bone like a jigsaw puzzle. Whereas if it's an ossicle, normally they're well rounded, well corticated. And the important thing to remember is there are numerous ossicles around the foot and the ankle. And I've included here again from Greenspan the numerous accessory ossicles. There we have the ostrigonum. So it's really useful to familiarize yourself with the accessory ossicles so that you don't have that confusion whether it's a normal variant or whether it's an avulsion fracture. And here we have an accessory navicular ossicle. And then the one that is quite common is the ostrigonum. and it can simulate a fracture of the posterior process of the talus, but you can see that it is really well corticated. And another one that can cause confusion is the osperonium, and this lies within the tendon of the peroneus brevis. And again, well corticated. And then something that's extremely common is the calcaneal spur, and the length of that, of course, can vary. Now, moving on to the foot. So the Ottawa foot rules indicates that a patient should be referred for an X-ray if they have pain within the midfoot or bony tenderness at the base of the fifth metatarsal, bony tenderness at the navicular bone, and then also inability to weight bear. There are a number of causes for foot injury. So talar injuries can occur when you fall from a height onto your feet, or if there's a violent ankle dorsiflexion, which can happen with car accidents. Calcaneal fractures, as mentioned already, quite often occurs because of fall from a height. Now, upper and midfoot dislocations is when there's severe twisting of the foot, and again, car accidents could be one of those. Metatarsal fractures and dislocations, when there's direct trauma, and that includes falling objects onto the foot or crush injuries. Avulsion fractures of the base of the fifth metatarsal, that's due to an inversion injury. And then, of course, stress fractures is due to prolonged exercise. I've again included a slide with images for you to go and revise the labels in the different views that's been taken of the foot, and there is a lateral as well. And then just to be aware of the joints, so we have Chopard's joint, and then we have Lisfranc's joints, and then of course the joints, the talar, calcaneal or the subtalar joints as well, which is there. And this is just on an X-ray, which indicates where you will find Lisfranc's joint, and then also Chopard's joint, and then of course all our other joints on the foot. Now, sesamoid bones are quite common, and especially around the big toe. However, these bones can cause confusion because they can be bipartite, tripartite, or multipartite. They can also be unilateral or bilateral. So there is a variation in presentation, and it sometimes can be quite difficult to distinguish whether you are looking at a fracture or whether you're looking at a sesamoid bone. So one of the key things, so when we look at this image here, we can see once again well corticated margins. So stress fracture normally occurs through prolonged exercise. It tends to affect one metatarsal and quite often the second or the third. Plain X-rays are not as sensitive immediately when the patient starts complaining of pain. Sometimes you might see some early signs of fluffiness, which would indicate early callus formation. CT or even nuclear medicine is quite useful. It's much more sensitive in identifying stress fractures, especially when you have a professional athlete that if they get a negative result might go on and continue exercise, and if it's not diagnosed, this is what it can look like then. So this is where there's been a missed stress fracture, and this patient had continued exercising, and yeah, not a good outcome on this one. Now, fractures of the base of the fifth metatarsal, you can have avulsion fractures, so it's quite common because of the pull on the peroneus brevis tendon. The fractures tend to be transverse, and it occurs mostly at the proximal tip of the fifth metatarsal. Now, Jones fracture occurs higher up, so about 2 centimeters from the tip, and it's caused by twisting inversion injury. It's something that's actually quite more common in ballet dancers, and it's not due to peroneus brevis avulsion. The one complication is that there's poor blood supply in this area, and it may result in delayed union of the bone. Now, it can be tricky to distinguish whether you are looking at a normal variant, which would be an unfused apophysis at the tip, or whether you're looking at a true fracture. So if it's a fracture, the fracture line is normally transverse. If it's an apophysis, the fracture line is normally either oblique or lengthwise. So it's the direction of the fracture line that's quite important in identifying whether this is just an unfused apophysis in the pediatric patient or whether it is a true fracture. Fractures of the metatarsal shafts are quite common, so when you look at the fracture, it's to identify whether it's in the shaft and whether it's near the base or near the neck, and also whether there is any displacement. Now, Lisfranc fracture dislocation, it's really important to pick that up. Sometimes it can be quite subtle, but if missed, it can have severe complications for the patients. So on the DP view or the AP view, to assess whether you're looking at a normal Lisfranc joint, the medial margin at the base of the second metatarsal should align with the medial margin of, and this is the cuneiform. And then on the oblique view, the medial margin of the third metatarsal should align with the medial margin of the lateral cuneiform. Now, when there's Lisfranc fractures, there can be associated fractures as well. So fractures to the basis of any of the metatarsal is quite common. You could also have fractures of the cuneiform and the navicular. There can be displacement involved, so homolateral fracture dislocations, and that's where the first to the fifth metatarsal is dislocated laterally. And then you can get divergent dislocation, and that's where the second to the fifth metatarsal has dislocated from the first metatarsal. So there's a widened gap between the big toe and the second metatarsal would indicate that there is a divergent dislocation. So this is just an example of Lisfranc dislocation. So you can see there's disruption in the Lisfranc joint, which involves the tarsus as well as the metatarsus. It's a severely comminuted fractures around that area. There is some separation as well, so this is a divergent fracture. And the other important thing to note is that the fracture actually goes through the skin, so this is also a compound fracture. And within the skin itself, there's this black gas within that, and that indicates that there is surgical emphysema. So other foot types of injury is to look at all of the bones that make up like our cuboids, the navicular and the cuneiforms, of course. These can be quite rare and normally result from severe trauma. So test yourself, look at this X-ray and see if you can identify where this fracture lies. So this is quite evident that there is a fracture there as well. Now, fractures of the phalanx are also quite common, and it can be from objects falling onto the toe or some crush injuries. Here we have got the big toe as well, comminuted fracture. Now, there's multiple lucent lines, and this was due to a crush injury. It's important when X-rays are taken that there is a true lateral view. So if we first focus on the AP view of the big toe, you immediately pick up there's definitely something going on in the joint. So between the metatarsophalangeal joint, the first one, the proximal, you can see there is something going on. But on the lateral view, you can clearly see that this is a true dislocation. So it's important that true lateral views are taken of any of the digits. With pediatric patients, there is a toddler's fracture. This normally happens when the baby starts to walk and they fall quite often, or their feet get stuck, and then you can have a subtle spiral type of fracture, and here is where it has started to heal. Now, a triplane fracture, and it's also one that you will see in the pediatric patient. It's quite complex. To see the fractures can be quite subtle. So on the AP view, you should be suspicious if you see any lucencies, which indicates there's a vertical fracture of the epiphyses. And then again, CT is really important. So the patient needs to be referred for a CT scan so that it can demonstrate that the fracture runs through the sagittal, the coronal, as well as the axial plane. Of course, with our pediatric patients, we shouldn't forget about non-accidental injuries. So fractures can be considered pathognomonic for NAI. If you see bucket handle fractures or metaphyseal, and you see that when the infant is shaken and the limbs are left to flap around, you could see fractures at different stages of healing, which is, of course, a sign that would flag that you're looking at NAI, and especially if the parent or the carer can't provide an adequate explanation. However, if NAI is suspected, then a full skeletal survey must be done, and also useful to include bone scintigraphy to exclude any subtle fractures. So this has now come to the end of the three parts of the pelvis and lower limb image interpretation. So just to remember, always apply the ABC search strategy so that you can distinguish what is normal from abnormal. And as I showed in this presentation, there can be a lot of normal variations as well. And then apply alignment principles to each of the joints so that you can ensure that you identify dislocations or fractures. And soft tissue signs are really useful, and in particular in the knee, lipohemarthrosis. So if you see a lipohemarthrosis sign, you should know that there should be a fracture. So if there's an occult fracture on the x-ray of the knee, the patient should be referred for a CT scan. And then know the common fractures associated with the pelvis and lower limbs, and some of the common pathologies as well. And then just to remember to differentiate when a fracture is near the joint space, whether it's intracapsular or extracapsular. And then the importance of apophyses. So if we are looking at the unfused pelvis, not infused, I see I've written there, to appreciate that this could be possible avulsion fractures. And then also to apply epiphyseal fracture classifications in the pediatric patient where the fractures are near the joints. So as always, please feel free to contact me should you have any questions.